Hello. Hi. Okay, I know Brees is on. Can you hear me now?
Yeah, we can hear you.
Okay, Dick just called. Could somebody send him the link? Be easier if somebody else does it. Either Rebecca or Zachary.
Okay.
Great.
I'll,
He just couldn't get on at
okay.
his Godfrey assembly.
Okay.
Email.
I'm gonna
Right.
send him right now. Give me one moment.
So as I mentioned earlier, we're just going to wait for the assembly member to
I
join,
don't
and
know
then we'll
if
get
you heard.
started.
He called me.
I heard.
Yeah, you heard me. Okay.
Yeah.
And is Brees back on?
Yes.
Great.
Yeah.
How you doing, Brees? I haven't seen you.
Doing well. How are you? Happy New Year, everyone.
Happy New Year.
Okay, we've sent out the Zoom link.
Great. And if Corey from Rebecca's office comes on, he may want to say hello. He said he's
He's
traveling.
here.
Oh, he
He's
is. Oh,
here.
hi, Corey.
Hi, Barbara. How are you?
Okay.
Okay, he texted me back saying the link isn't working. They are resending it. So that's probably a slightly delayed text.
Okay.
Yeah. Zachary just sent it to you, Brees, and him. So you should have it in your inbox.
Oh, okay. My email, maybe. Okay.
Yeah.
Hang on.
Yeah.
Brees, is he in Albany or in New York?
He is probably in Albany. Or maybe he's heading up tomorrow. I don't remember.
Yeah, because I know Rebecca's on her way.
Yeah, he may be.
He's calling me now. I think that's him again. Hello. Oh, it's coming through. Don't worry, we're chatting. And but I think Brees is sending it to you and Zachary from the office. I think that we're all sending it to you, Dick. Okay. We just appreciate you coming so much. Thanks. Okay, bye-bye. He said the email has not come through yet.
Yeah, I haven't gotten anything either on my end. So here we
It's
go.
that Staten Island.
I see it now from Zachary Glass. Yeah, I've got it.
Yeah, that's right.
So I can't blame it on Staten Island, Zachary.
Not today.
Frankly, probably the assembly servers. Because
What's the new Staten song?
most of the assemblies operating a remote, and I think it's putting a big strain on the system. Things seem to be quite
Yeah.
slow.
So Zachary, do you want to go ahead and give the instructions for how the meeting's going to run?
That as well.
And
Yes. Okay, here we go. Welcome. If this is your first time joining us, everyone will remain muted throughout the meeting except committee co-chairs Barbara and Rebecca and the presenters. Following the presentation, co-chairs will call on members of the public wishing to speak. You can participate by going to the reactions icon, pressing raise hand, not the wave or thumbs up buttons. Only press it once. If you press it a second time, your hand will go back down. If you are on the phone, it is *9 to raise hand and *6 to unmute. Be on the lookout for a prompt asking you to confirm unmuting once the co-chairs call on you. The chat is for technical support only to help with Zoom software problems, not to ask questions of the co-chairs. They will not see the chats. If you have an older version of Zoom, you will need to go to the participants section where you will find the raise hand feature there. Please do not raise your actual hand or wave at the screen because we may not be able to see you. Chat me, I'm here for support.
Thank you, Zachary. Corey, do you want to give any words from the assembly member?
Sure thing. Thank you so much, Barbara. I'm Corey. I'm Assembly Member Seawright's Chief of Staff. The Assembly member would love to be here right now, but she's traveling up to Albany as a session is starting this week. I'm very excited for this part 2. We were really happy Assembly Member Godfrey was able to come a second time, and I'm definitely eager to report back to the Assembly member anything that happens. And as always, use our office as a resource or ask any questions. My email address is Hasson, HASSONC, as in cat, at nyassembly.gov, and our office is 212-288-4607. And I'm going to be reporting back to the assembly member what goes on at this meeting, and if there's anything else, just feel free to let me know.
Thank you so much, Corey.
And I'm here now.
Oh, wonderful. Good. I'm going to give a 2-minute speech, okay, Dick, just to say hello.
Okay.
So, this is the Health Senior Social Services Committee. I'm co-chair with Rebecca and Dan Gore, and Wilma Johnson, unfortunately, is getting tested right now because she's having some signs of things, but she may join us soon. As always, we want to thank Zachary Glass for being so great, and Will, that's always there for us. So thank you very much. We welcome the Assemblyman, Richard Godfrey, who is the longest serving assembly member of New York State Assembly. That is right, right? It's almost more than a half a century. Unfortunately, he will be retiring this year, but the effects that he has had will be remembered and lauded and have the effect on us for a long time. So many of the vulnerable he has affected, such as the LGBTQ community and children. He passed the children's, what is it called? The Health Act, the exact name with it. The last meeting, we held a meeting with Rebecca Seawright, as Corey had said, and Richard Godfrey came to talk about problems we have, what we see in our community, the Upper East Side, where Medicare and insurance generally is not being accepted by the doctors. Our Assembly member Godfrey has been an ardent supporter of equality of healthcare and has been working on the New York State Health Act and has agreed to come back. This is your fourth time coming back to us, Dick. We had two very big forums discussing it, and last time and now again to answer. It's a complicated but an important issue, and we're so pleased and thankful that you're coming back to us. After we hear from remarks, we will open up for questions. So thank you so much.
Okay, well, thank you very much for having me. It's always a pleasure to be with Board 8, and I'm doubly happy because I'm always eager to talk about the New York Health Act. And by the way, while I will not be running for re-election, I will be serving to the end of this calendar year. So you're not done with me quite yet.
Great, we could have you the fifth and sixth time.
So, almost every problem we face in health and healthcare is made worse and harder to solve because of the crazy way we try to pay for healthcare in this country. For example, over a third of households in New York report that in any given year, one or more household members either goes without needed healthcare because they can't afford it or suffers financial hardship having to pay for it. And these are households with health coverage. No one thinks that's right. But actually, the New York Health Act is the only plan on the table that can really deal with it. So what's wrong with our current system? One is premiums that rise every year faster than inflation, faster than wages go up. Premiums that, the insurance company doesn't care what your ability to pay is. They want the same premium, whether you're a multi-million-dollar a year CEO or the receptionist. Deductibles, likewise, growing faster than inflation, faster than wages, into the thousands of dollars, which means the insurance company doesn't pay for your care until you've paid a whopping deductible. And for a lot of people, that makes their health insurance almost worthless. Even once you've met your deductible, you have copays. And for many people, having to pay the copay is an obstacle to using their health insurance and getting access to care. Restricted provider networks. You don't decide what doctor or health plan to go to, not if you want your insurance company to pay the bill. They decide what doctors, what physical therapists, what lab, what hospitals are in their network. And if you go to a provider that's not in the network, you're going to be paying an awful lot of money if you try to do that. None of our conventional health coverage covers long-term care, meaning home health care or nursing home care for a long period. And I know from personal experience with my mother that a family that has accumulated a lifetime of savings can have those savings wiped out in no time by the costs of long-term care. And in other words, everyone in New York is underinsured. We hear people talk about, well, there's only 5% are uninsured, and yes, there is some underinsured. The fact is, everyone in New York is underinsured. And why is it that a system that spends so much money has such deep problems? And part of the answer, large part of the answer, is that we waste over $60 billion a year in New York in our health coverage system. Biggest chunk of that is what we waste on insurance company bureaucracy, marketing, and profit. On top of that, doctors, hospitals, and other providers spend an enormous amount of money, about the same amount of money as insurance companies spend, on administrative costs, largely for the purpose of fighting with insurance companies. Our neighbors to the north in Canada, which has a single payer system, their doctors and hospitals have about half the administrative costs that we face here in New York. And prescription drug prices are as high as they are because no one in the healthcare system today has the bargaining clout to bargain effectively with prescription drug companies. No single health plan has enough bargaining clout to do that. And again, no one says that this is the right system. No one says that a system like this is justifiable. And yet there is no plan on the table to deal with all these problems except the New York Health Act. So what does the New York Health Act do? First, it covers everyone, all 20 million residents of New York, no matter how old or young you are, rich or poor, no matter how you got here, whatever your immigration status is, all 20 million of us would be covered just by being a New York resident. And the benefits are the most comprehensive of any health plan. I have yet to have anyone say to me, gee, I have a health plan that covers X. Does the New York Health Plan cover that? And the answer wasn't yes, of course. And of course, as I said, the New York Health Plan covers long-term care, home care, and nursing home care that almost no health coverage covers. And it provides consumers with real choice because there is no restricted provider networks, and that goes for drugs as well. So you've got not only complete coverage of benefits, but complete choice of healthcare provider. And the New York Health Act pays the whole bill. No premiums, no deductibles, no copays, no out-of-network charges because there are no restricted provider networks. Now, fair question is, gee, this sounds terrific, but how can you pay for it? And there are a couple of basic parts to the answer. One is that the over $60 billion in waste that is attributable to the current system of health insurance companies, we save that $60 billion in waste. So we start out with that money in our pocket. Secondly, the plan is paid for primarily, it's paid for by a progressively graduated tax. Progressively graduated meaning income in the lower brackets is taxed at a lower rate than income in the higher brackets. And that's a tax that's levied on earned income, meaning like salary, wages, et cetera. And it would also be levied on dividends and capital gains and interest and the like if it is currently subject to the New York State personal income tax. And by the way, when I say it's progressively graduated, the first $25,000 of everyone's income would be completely exempt. And if you're on Medicare, the first $50,000 of your income would be exempt, in large part in recognition of the fact that being enrolled in Medicare, you would be helping to draw down a dramatic amount of federal funding into our healthcare system. And what all that means between the savings, between being the funding being based on ability to pay, 95% of New York households would be spending less on healthcare and health coverage than they are today. 95% of households would be spending less than they are today, and the system on a whole would be spending less than it is spending today. What are the guarantees that it'll be a good plan? The basic guarantee, first of all, everything I've just said to you will be written into statute, into law. But the other protection for the plan that will keep it from being degraded in the future is that we will all 20 million of us, be in the same boat. People who have no bargaining clout will be in the same boat with the wealthiest and most powerful New Yorkers. And anytime the governor or the legislature thinks of tampering with the New York Health Act, they will know that they're tampering with the health plan that covers them and their families and all their friends. And so the fact that 20 million of us will all be in the same boat, all in one big negotiating or bargaining unit, is the best possible guarantee to make sure that the plan will stay as top-notch as it starts out. Some people ask, well, if this is so terrific, why not make it an option? If people want to join in, they can join in. If they don't want to join in, they won't. The answer is that leaves us still with a fragmented system that we currently have. And it's that fragmentation that produces the $60 billion in waste that costs us so much money. And so the only way to get rid of all of that waste and to fund the system and get all the benefits of the New York Health Act is if we're all in the same boat together. And also that also makes sure, if people who have real wealth can buy out of the system and pay for their own coverage, then they will not have any political incentive to keep the plan a good plan. I want wealthy New Yorkers in the same plan with the rest of us so that they will use their political clout to make sure that the plan is kept as good as it can be for all of us. Now, you might ask, how can we make this thing happen? And the answer is, if all of us speak up for it, if the organizations that we're part of speak up for it, if the organizations that we're part of, if we get them to speak up for the bill, we can make this happen. Already a majority of New Yorkers support the bill. Obviously, there are some very powerful special interests that don't support the bill. So it's going to take a lot of effort. The bill has been before the legislature for a number of years. I believe this is the year. We've got more support for it than ever. We've got a majority now of the members of both houses of the legislature on as co-sponsors of the bill. I believe that if we all stick together, we can make this happen this year. Thank you very much. I'd be happy to answer any questions you have.
Wonderful. Rebecca, are you going to, or is Zachary going to call on people to
Yeah,
answer?
I'll go through it. We'll call on members of the public first. So let's start with Erica.
Hi there. Happy New Year. Thanks for coming back again. The last time you presented at the last meeting, so I have two questions. The first one is about, you referenced appeals, and I don't understand why there would need to be appeals if we're getting away from that and we're getting away from all the paperwork. And my second question is, you're also talking about employers paying into, again, if you look at other systems that have universal coverage, employers have nothing to do with it. I lived in Switzerland, so I know what the ACA was supposed to be built on. Employers should have nothing to do with it. So why in this case, two questions. Why were you talking about appeals, and why are employers going to be included in this?
Okay, well, the system would not have any system of prior authorization, which of course most insurance companies have, but there would be occasions when an insurance company would see a bill coming in for something that just should not be paid, either because it was for a service that did not match the patient's diagnosis, or it wasn't for a covered benefit. For example, truly experimental care, is ordinarily paid for by research funding, not by health insurance. So there would
It's actually not true. I work in clinical research, and clinical trials. A lot of things are covered by clinical trials.
Yes,
so.
there are under New York law, there are stages of clinical research where something has been established enough that insurance is required to cover it. But there are some circumstances, not many, but there are some circumstances in which an insurance company would still be able to say no, in which case the bill provides, using the current system of impartial appeal mechanisms as an appeal. And that has to be built into any system. I mean, you could imagine, even far-fetched examples where a doctor would be submitting a bill that clearly should not be paid. And that's why there has to be an appeal system. You asked why there is a tax on employers. Somebody's going to be paying the tax. The reason we levy part of the tax on employers is because that that's the closest analogy to how the system is funded today. It would not be a matter of choice for employers. They would have to pay at least 80% of the tax. They could choose to pay more, for example, through collective bargaining. But that's roughly the way coverage is paid for today. And we felt that there would be as little as possible in cost shifting if we followed the current model.
Right, so people like me who own our own businesses and are consultants bear the brunt of the full cost.
Right. Today, if you are self-employed or a sole proprietor, you are paying the full cost of your health coverage. And under the New York Health Act, you would pay the full cost of the premium. Although, unless you're an extremely wealthy self-insured person, that cost would be substantially less than you're currently spending. Whoever we decide to tax, there will be somebody saying, don't tax me, tax the other folks. That's unavoidable. The current mechanism, I think, because it is analogous to how we currently distribute the burden, probably makes the most sense. If people came up with a fairer distribution of the revenue, I'd certainly be open to that. The one major change from the current system that it makes is that so-called unearned income, like capital gains and dividends, which is where the big money in our economy is earned. That income, if it's currently subject to the New York income tax, in other words, not counting, for example, municipal bond interest, that income would also now be contributing to the tax. And for almost all New Yorkers, that would significantly lighten our burden.
Thank you.
Yeah, you're welcome.
All right, next, let's go to Judy Schneider.
Hi there, thank you. So if the assembly member, if this insurance was passed, we, people like myself who are on Medicare, we would still be receiving our Medicare as well as coming under this plan, is that correct?
Absolutely. First, I mean, legally, there's no way New York State could touch anybody's Medicare benefits. And we certainly would not want to do that. We want to keep having Medicare spending its money in New York State. We want to keep Medicare beneficiaries getting every right and every benefit they're entitled to. The New York Health Act would be on top of that. So the out-of-pocket costs that you now have under Medicare, the New York Health Act would pick up. Nobody would need to buy a Medicare supplemental plan anymore. If you were in a Medicare Advantage plan, there would be you would not need to be in that plan to get the extra benefits, and that means you would not have restricted provider networks and the other problems that come with Medicare Advantage.
Well, it sounds terrific to me, and I just want to say to Rebecca and Barbara that I think we should pass a resolution supporting it. And if the full board supports it, Russell, I hope that you would bring it down to the borough president's meetings and get the other boards to also do the same.
Thank you, Judy. Let's get some more questions and ideas going through. Yeah. Rebecca?
Next is Lori.
Okay. Hello, Assembly Member Godfrey, and thank you again for your energy in continuing to push this, because it is so essential, and I'm a big supporter. I just want to give you a real life example of the problems you mentioned, the problems with Medicare Advantage. And I wanted to tell everyone about a recent issue that I've been dealing with. I have multiple sclerosis, and I've been on the same drug for 20 years. And it is frightfully expensive, as all the MS drugs are. $115,000 a year for one drug. Okay. But this drug has kept me upright, has kept me seeing, and has kept me to the point where nobody, unless I told you, nobody would know that I had MS. And my Medicare Advantage plan started to send me notices saying, we are changing, we're not going to cover your drug anymore. And you can, consult your doctor and see if there's another drug that he would, want to prescribe. And they gave suggestions, none of which were appropriate. They didn't match, the chemical, the formulary or the formula that my successful drug has done. But anyway, so I called my doctor and I said, I discussed this with him, and he was like, I really, I don't know what to say, because, none of them are really close. And I said, okay, well, I'm a political person, so will you back me up if I make a big deal about this? And he said, of course. He goes, but I don't think you're going to, I don't think you're going to get anywhere. So anyway, this started a whole series of calls between me and the healthcare provider. And I was getting incredibly conflicting information. One day they said, okay, no, it'll be covered. Don't worry about it. And then I'd get another notice saying, we're not covering your drug anymore. And then I would call them again. And then I would get another notice, and it was back and forth to the point where at this point today, I'm not sure what's going to happen. I haven't, I've stockpiled the drugs so that, I have a supply on hand, but it is terrifying to think that this drug that's kept me healthy, for 20 years is suddenly, they're just going to cut it because they feel like it, because it's, bean counters. So as I said, I fully support this. I think that it's really important that we do it. And I appreciate all of your efforts. And if there's anything, the last time you were here, you said that we should contact the governor and tell her of, and I did that. But what else can we do? I mean, you said, go to our organizations. A lot of the organizations are connected with the drug companies, in my case anyway. So it's a little difficult to do that. But anyway, I'll stop talking now and just, give me your continuing advice.
Okay, well, thank you. Well, certainly one thing Board 8 can do is adopt a resolution supporting the bill. And I think the idea of you then taking it to the borough board is a terrific idea. And get all of Manhattan on board with the bill, and communicating that to our new governor. The problem you raised about your drug not being covered, I think an awful lot of us have similar problems with our health coverage. I have a drug that I take on a long-term basis. It's not aimed at as a problem as serious as multiple sclerosis, and the price tag is a whole lot less than your drug's price tag, but it's important to me. And my health plan just informed me that starting 2 days ago, they're not going to cover it anymore. And they offered me an alternative drug. And, I talked to my doctor about it, and he said, well, it's almost as good as the drug you're on. It has significant drawbacks in terms of having a higher chance of complications with it. And I said, well, the drug, the health plan said you could apply for prior authorization. And he said, yeah, I know that, but based on his experience, he said, there's really no point in it. They're not going to approve it. And so I'm just, since I'm not about to pay out of pocket, I'm going to have to settle for a drug that exposes me to a little more danger than the one that I've been on. And that's a problem we all face at one point or another with our health coverage. And there's just, it makes absolutely no sense in a society as wealthy and progressive as America and New York. And it doesn't have to be that way, and it would not be under the New York Health Act. So thank you.
Oh, thank you. Just one other question. Can you explain the issue of pharmacy benefit managers? I'm sure that you know about that. That is a really, I think people should know about that. Go ahead.
Well, that would be a longer discussion. Short, good piece of news is that the legislature passed a bill of mine this year that will, I think, start to bring about some powerful regulation of pharmacy benefit managers. These are the companies that insurance companies contract with to run their pharmacy benefit. So actually, the people who told me I could not have my drug anymore, and probably the people who told you you couldn't have your drug anymore, they were doing it under a contract with our health plans, but it was not our health plan that really made that decision. It was the PBM. The governor signed that bill, and I'm hoping that it is going to start to make a difference, at least here in New York State.
Thank you again.
You're welcome.
And just following up on that, before I call on Alita, you did say that, with the New York State Health Act, restricted provided networks would go away and it would be the same for drugs.
Right.
Does that mean if brand name drugs would be covered even if a generic is available?
A brand name drug would be covered because under the system that the bill includes, if a doctor prescribes a drug that is not on the preferred list for the plan, the doctor would then have to go through what I think of as a speed bump. The doctor would have to call the health plan and explain the doctor's reasoning, but ultimately the bill says the doctor wins. Now that the system I'm just describing used to apply to all of the New York Medicaid program. And when it did, 99% of prescriptions were for drugs that were on the preferred list, because the way that list is put together under the plan that I'm talking about, doctors had a lot of confidence in it, and they felt it was a reasonable list. And so almost every prescription turned out to be for a drug that was on the list. And by the way, every drug that I take that has a generic equivalent, my doctors prescribe the generic equivalent, and it makes perfect sense. There are rare cases where the brand drug may be preferable, and in those cases, if the doctor insists on it, the doctor would win under the New York Health Act.
Okay. That's good to know. I do agree with you. Most drugs are generic works as well, but there are some very expensive drugs where doctors do prefer to prescribe the brand name, especially if there's, a certain dispensing system that's different. Okay, let's go to Alita.
Thank you, Rebecca. Happy New Year, everyone. And thank you, Assembly Member, for coming back. I'm still confused about the appeals process because I don't really understand. There's got to be a line, and I don't have any details for where that line is. I'm not sure why doctors would stay in New York if their income here would be restricted because they're limited to what is available to them through the plan, why they wouldn't just go to a state that has lower taxes and private insurance. I'm also not convinced that the super wealthy people will stay in New York and make sure that the plan works because they could get treated anywhere in the world that they want to. And I have in-laws in Canada, and I have a very good friend in Canada who's being treated for cancer. There's a lapse of time between treatment and diagnosis that the severity of the disease does not seem to impact the time of treatment. And there are delays that could have, for serious diseases, a real impact on health. And I know this from personal stories. I know that doctors in Canada are paid under the table as well. I know that from people who did that. So I just am not hearing, and I don't mean any disrespect, but enough details about how this is going to really work. I hear a lot of wishful thinking that doctors, and Lori, I mean, I have no words to describe
Could
the
we-
angst that you must feel and that
could
people
we do
must
2 or
feel
3
for going
questions
through
at a
all of
time?
this. So I understand that. I'm sorry that we need to fix
at a
it, but I
time.
don't know what the answer is.
Okay.
Sorry.
You've asked about 4 questions.
I know, and I'm sorry.
Okay, and I've already talked about the appeal process. I can talk about it again if you like. There would be the mechanism that is currently in the law. It defines the term medical necessity, and it says if a plan finds that a given treatment is not medically necessary, then it goes through an internal appeal process in the insurance company. And if the patient or the doctor still wants to appeal, it goes to an external appeal process, essentially an arbitration process. And that's a process that has been operating in New York for a number of years now, and it works actually quite well and quite fairly. As to what doctors will get paid, people seem to assume without any basis for it that somehow we're not going to pay doctors and hospitals fairly. There are 2 basic safeguards that make sure that doctors and hospitals will be paid fairly. One is the fact that as a member of the legislature, I want to make sure that the doctor that I go to and the hospital that I go to is going to be paid fairly. And I'm going to make sure that my health plan, the health plan that covers me, treats my doctor and my hospital fairly. And 20 million New Yorkers will benefit by being in the same health plan with me and the governor and all my colleagues in the legislature and all my friends and all of my family. So that's one safeguard. The other safeguard is that the bill has explicit language in it that guarantees that reimbursement rates will both be reasonably related to cost and will be sufficient to assure an adequate supply of the care. No health plan today has that kind of assurance. And lots of our health plans radically underpay our doctors. And if you've got the money and can pay out of pocket, well, I guess you're okay. But an awful lot of our doctors get seriously underpaid in this state. And under the New York Health Act, because of language that is in the bill, and by the way, we went to the Medical Society of New York State, which believe me, is as concerned as can be about making sure that doctors are well paid. And they gave us language to put into the bill to specify the methodology for how doctor and hospitals and others will get paid. That's the language in the bill. It came to us from the Medical Society of the State of New York. So I think you put all that together, that's about the best guarantee possible that no, doctors are not going to flee New York. They're going to get paid every bit as well as they are today. The only thing they're going to get paid less for is there will be a reduction in what they get paid to reflect the fact that they're not going to be spending an enormous amount of money on administrative waste and time and money and effort fighting with insurance companies. Doctors will have an easier time practicing medicine in New York and will be paid just as well for their clinical services as they are today. And so all of these notions that, oh, there are going to be waiting lists, what have you, are based on the assumption that doctors aren't going to get paid well and they're going to flee New York. None of that is going to happen. There were fears like that when Medicare came in, and none of that happened either. And so you put all that together, and it is the best possible plan, not only for you and me and 20 million other New Yorkers, but for the doctors and hospitals that serve us. One problem that Canada has that sometimes results in waiting lists is that they've got a population about the size of the state of California, but spread out over an area 2 or 3 times the area of the United States, which means that it's hard to maintain a full complement of the density of supply of specialists and specialized hospitals and services that we can have, for example, in New York. And because of their population being so spread out and their healthcare providers as a result being similarly spread out, it is often difficult to get access to the services that we, for example, in Manhattan, are accustomed to. But it's not because their health system does not pay adequately. It's because of the nature of their population and their geography.
Well, these are people in the 3 largest cities in Canada, but I have one more question or one more point.
None of their 3 largest cities is even in the ballpark of the 100 large, probably the 20 largest cities in the US.
A lot of the problems that you've talked about come from the big pharma, and drug companies sell their drugs at reasonable rates in Europe, and then they sell them over here for multiples of that, for much higher. We know what happened with that drug, the AIDS drug, I guess, that someone bought the company and raised the price to hundreds and hundreds of dollars. We know that Medicare just disapproved paying for Alzheimer's medication. How do we know that when the bean counters in the government see all of this, that it's not going to be an issue? Rebecca raised the point of the.
Here's the answer to that. Let me answer that question. We will have the bargaining clout to bring down those prices, and no drug company is going to walk away from a market of 20 million people. They might walk away from selling their drug to an insurance company with 100 or 200,000 customers. No drug company is going to walk away from a market with 20 million New Yorkers.
The federal government can't even negotiate. Sorry.
The federal
government can't.
The federal government does not negotiate drug prices with drug companies. The Medicare program is in fact prohibited by statute from negotiating drug prices with drug companies. That's why our drug prices are through the roof, because nobody has the bargaining clout that it takes to bargain with those folks. The New York Health Act will have that bargaining clout.
And they're a lobbyist, but I won't keep you anymore. I know that there are other people, but I thank you for your patience.
Rebecca, when everybody's done, I have several questions to ask. I don't know.
If anyone else has a question, you can raise your hand and we'll call on you after Barbara asks her questions.
I have a lot. I'm going to start with one that surprised me. My memory, which may be wrong, was the last time we spoke a few years ago, Medicare was being removed, that this was not supplementing Medicare, but replacing Medicare. Do I understand you're saying now that there will still be Medicare?
Your recollection must be wrong. I would never have said anything faintly resembling that we would be doing away with Medicare.
I thought you were using the Medicare money to supplement this.
No, not at all. Under the New York Health Act, every nickel we get from Medicare would continue to flow into New York, and every benefit, every right that every Medicare recipient has would continue to be guaranteed. The New York Health Act would be on top of that. Now, if the system could be run, if the federal government wants to cooperate with us, could be run by merging Medicare into the New York Health Act.
That's what I thought.
The federal government would basically be sending us a check every month for what they would have spent under Medicare in New York. But that phone ringing will go away in a minute.
Okay.
But under the bill and under federal law, Medicare enrollees would be entitled to every benefit they're now entitled to, plus whatever extra they would be getting. And they would be entitled to every right that they now have under Medicare, plus whatever they got under the New York Health Act. Even if we wanted to, which we wouldn't because we're not nuts, we could not touch people's Medicare benefits. The federal government wouldn't let us, and we'd be nuts to try.
And you're saying the same with Medicaid also? Is it the same
with Medicaid? And the bill says that. The bill provides that quite explicitly. Yeah.
Okay. Then let me ask you just some questions. If a doctor takes Medicare but does not want to take the New York State Health Act, and for whatever reason, how would it work? Or vice versa, if they take in the New York State Health Act but not Medicare, what will happen?
Well, first of all, that doctor would probably need to have his or her head examined, because they would be saying, I'm happy to treat you, but I'm going to turn away free money that I could otherwise get. I can't imagine a doctor who would say, I'll treat you and I'll take the $1,000 that Medicare will pay me. But if the New York Health Act is going to pay me an extra $500, I'm not going to take their money. I'm going to settle for the 1,000. I'm going to refuse the extra 500. No doctor would do that. They'd be nuts to do that. Likewise, no doctor would say, I'll take the state money for your treatment, but I won't take the money that Medicare would give me. I mean, I suppose they could, but again, they'd have to be insane to do that.
Okay, I understand that, but there are doctors that would take neither. That certainly many, and that was our whole start, that do not take Medicare.
There's a very tiny percentage of New Yorkers who can afford to pay for their health care entirely out of pocket. And therefore, there is a tiny percentage of New York doctors who can afford to only live on what patients pay them out of pocket. As the bill is now written, if a doctor wants to not participate in the New York Health Act, we would not force them to. Again, because the payment levels would be guaranteed to be adequate and reasonable, and that doctors would be better off than they are today. It's hard to see why doctors and hospitals would not accept the New York Health Act funding.
I hope you're right. I am one of those that I am going to a doctor that's not taking Medicare because, as I explained before, I had a horrendous medical situation where I was forced to be in the hospital and rehab for about a month and with lasting stuff. And my doctor wagged his finger and said, you need a good internist, and would not give me a name of an internist that took Medicare. I cannot. And I will tell you, Dick, that there are things that happen to me, like I may not feel well. And I stop and say, I'm not calling my doctor because he's going to charge me another $2,500 or whatever. However, when I can't leave him because my kids wouldn't let me, because when I was in a New Jersey hospital and my kids had to figure out what to do with me, this doctor came through, and I don't know if a Medicare doctor would do it. And if I want to keep my kids, I have to keep the doctor.
By the way, doctors who don't take Medicare, there are lots of news stories about that. You never see the news stories about the doctor, like my doctor, who doesn't accept any health plan except Medicare.
Yes, and I bet if I called him, he would not take me.
Yeah, my doctor does not accept my health coverage, which is annoying, but we like him as a doctor, and so we submit our bills to the health plan, and they pay us not as much as they would if he was in the health plan.
Right.
The only health plan he does take is traditional Medicare. And if you ask him why, he says, I send them a check, I send them a bill, they send me a check. No one else does that.
I know.
That is why more doctors take Medicare, fewer doctors reject Medicare than any other health plan.
Well, without going into that, and many of these doctors don't accept new patients and so on and so forth. But without going more, my next question, well, I want one more question about employers. How does it work? I mean, the two horror stories I have with insurance is when I was no longer working, I was changing jobs, and both for health reasons, I had left jobs and was on COBRA. And I have two different stories, but they were horror stories of not getting the medication. Why? I think that we heard a question about it. Why do you feel that this has to be associated with working? What happens if my company says you're no longer employed here and I lose my health benefit?
Well, under the New York Health Act, you would no longer lose your health benefit. You would be entitled to the New York Health, whether you're employed, whether you've never worked a day in your life, whether, no matter what, you would still be entitled to New York Health.
That's a great
would
answer.
happen?
Yeah.
What would happen is if you don't have an employer, then if you were self-employed or unemployed, if you were unemployed, your income would be dramatically less. And so your New York Health Act tax would be dramatically less.
And I wouldn't have any loss,
no loss in benefit.
No, but that's a great answer.
I don't know how many times I can say it. All 20 million New Yorkers,
right?
All 20 million New Yorkers, including people who don't work, people who've never worked, people who work every day of their life, all 20 million New Yorkers from Mike Bloomberg down to the poorest of us would be covered with the same New York Health Act.
I know. I was thinking when there's a gap period, when you lose your
There
job.
would be no gap period.
It would be no, that's a great answer.
Every day of your residence in New York, you would be covered just like I would be covered and Mike Bloomberg and 20 million other New Yorkers. You would never be not covered by the New York Health Act as long as you're a resident of New York.
Okay. Two more. One, I did speak to some union people to say, why are you against it? And you know the answer. The answer is they feel they have great health care and wanted some negotiation about it. Is there any chance there will be negotiation with places like the unions to just to get this through?
Much of the labor movement strongly supports the bill. I mean, I could rattle off the names of the major labor unions that support it. The key opposition is the public sector unions, who you say they have terrific health benefits. They think they have terrific health benefits. No one in America has terrific health coverage. Because all of us have health coverage that stinks if you compared it with the health coverage that our neighbors in Canada have, that people in wealthy industrial democracies all over the world have. No one in America has good health coverage. Not you, not me, not
do they know that they're going to have it? We heard about the firemen's widows and widowers that are losing the type of insurance that they were absolutely promised with, and so on.
So we're talking with the public sector unions. I hope we will bring them on board.
Okay, my last thing, and I'm going back to something you said about your Medicare doctor. You have the option of going to a doctor that doesn't take your insurance and getting some of the money back. I called it a PPO. Why can't we have something like that for Medicare and or for this? Not the opt-out. Not originally you talked about people say, I want to opt out of the New York State Health Act. Not opt out of it, but if I want to spend more money on insurance to get something.
Here's why. If Mike Bloomberg can pay his doctor out of pocket on the side, and if that's legal, then Mike Bloomberg, and I don't mean to pick on him, he's just, my favorite billionaire. If Mike Bloomberg, I want Mike Bloomberg's doctor, just like my doctor, to be dependent on the New York Health Act being as good as it possibly can be. I want Mike Bloomberg, I want billionaires to know that their doctor is getting paid the same as my doctor and the poor person's doctor. And the only way to do that is if we don't allow what is called balance billing. Because if we allow balance billing, the rates that the New York Health Act pays will sink, and the doctors that 19 million of us go to will be paid a whole lot less, because the doctors that the richest million of us go to will be able to take money on the side. And the best way to make sure that my doctor and your doctor and every other doctor is well paid is if all of them are not able to be paid a little extra on the side. And
that would be illegal to do it, because that's what
that is correct.
It will be illegal to do it. Okay. It's interesting, but Zachary just sent us an email from a concierge. Do you want to take good care of your mommy? Join this concierge practice. In other words, you don't have to visit them, just get an expensive doctor. So that's what's happening right now. And just
my doctor does that too.
Yes. Yes. And it's mine does too. Thank you very much. Rebecca, I will answer one thing if there's no more questions. Thank you.
There's a couple more.
Okay, great.
Okay, let's go to Ellen first, because she hasn't asked a question yet.
Great. Hi. So I think Barbara touched upon the concierge just in her last question, but I wanted to emphasize that these under Medicare, the doctors really aren't getting paid enough. I mean, we all know that. I'm wondering if the New York Health Act is going to pay those doctors that take Medicare extra to compensate for them. Will the New York Health Act pay more than Medicare?
Well, the answer is absolutely yes. And I hope I made that clear earlier. The New York Health Act, in fact, says in black and white that Medicaid and Medicare do not pay adequately under the standards of the New York Health Act, and that therefore it says the New York Health Act will pay more than Medicare and Medicaid pays. And not only is there that couple of sentences in the bill, but the explicit language in the bill that talks about payment methodologies makes that doubly clear. No doctor will ever again have to live on what Medicaid and Medicare pays. They will all be paid substantially more than what Medicare and Medicaid pays.
So how does that work if we go out of state? Like right now, I'm in Florida. So how would that work if I needed to go?
If you are, okay, if you're a New York resident and you are temporarily out of state, whether it's because you're spending a couple of months living in Florida or because you're on vacation and you break your ankle hiking in the Grand Canyon, or if you live in Dutchess County and the hospital you go to is across the border in Connecticut, the New York Health Act will pay your out-of-state provider. Now, if you're no longer a resident of New York, the New York Health Act will obviously not pay you because the New York Health Act pays for the healthcare of New York residents.
Mm-hmm. Okay. I have one more question. I know every time I see you, I ask this question, so I'm going to try, and I keep trying to phrase it a little bit differently because I work with older adults, and many of whom are on Medicaid and getting home care. So I'm trying to wrap my head around all the extra people that would be getting home care through Medicare, through that are on Medicare and need to have home care through the New York Health Act. Or if you break your ankle and you need to get some temporary home care, how would that work? Would it be the same system that we have now, or would there be, would you set up a CASA-like system where somebody would be evaluated to determine the number of hours that they need, or have you not figured that out yet?
Well, as there is today, there would be a system for assessing how many hours a day of care somebody needs. It would not be run by managed care plans, which is how it's run today. And because today that system basically applies to people who have impoverished themselves and are on Medicaid, and programs for poor people tend to be poor programs. Because it would not be just for poor people, it would be run a whole lot better, and it would pay for home care as well as nursing home care a whole lot better than it now pays, because of the language of the bill that would ensure that it would be paid for better. But you would not have to spend down or wipe out your assets in order to become eligible for it. Anyone would be eligible for it based on medical need, as it should be.
Okay, so like right now, it's virtually impossible to get the number of hours that somebody needs unless you hire an attorney and go to a fair hearing.
Yep.
So would we have the same problems that we have now, or would it become simplified?
It would be simplified because today you're probably dealing with a Medicaid managed care plan, which means that it's the worst possible combination. It's a combination of the state and a managed care plan that are making these decisions, and none of them has your interests at heart. None of them has to worry about whether 20 million New Yorkers will be angry at them. Under the New York Health Act, it will be dramatically different.
Okay, thank you.
Yep.
Alita?
Thank you. Sorry, I have a couple more questions. One, when you mentioned the $60 billion, I think you said the insurance company has in waste and that would fund the plan. if I have health insurance through my husband's job, aren't I one of the people paying for the waste that the insurance companies have? And how would that work to fund the plan? And my other question is,
Could we do them one at a time?
sure.
Okay, the answer is yes. A big chunk of your premium dollar contributes to the $60 billion in waste. A big chunk of your premium is what pays for insurance company administrative waste and for the administrative weight burden that doctors and hospitals put into their bills that your premiums have to pay for. Under the New York Health Act, part of the reason why the taxes would be lower than the premiums now are, as well as not having to pay deductibles and copays, is because we would be saving that $60 billion.
Right. I remember that you said, did I mishear you when you said doctors can opt out of this plan?
Doctors can choose to live entirely by out of pocket payment, but there would be hardly any doctors in New York that could afford to do that.
Well, what about all these concierge doctors, or the doctors that the people who earn 10 or 100 million or $1 billion a year go to? I can't imagine that they would be content to stand in line with everybody else.
Well, they wouldn't be standing in line. We talked about whether there would be lines, and there won't be lines. There are a handful of doctors, there are a small number of doctors who are lucky enough to build a practice based on multimillionaires and billionaires. If you think about it, it's got to be a pretty small number because there aren't all that many millionaires and billionaires in New York. They make a lot of money, but there's not tens of thousands of them. And so, yeah, there may be a small number of doctors who can make a nice living opting out of all health coverage, including the New York Health Act. I don't know how we could stop that, but the vast, vast majority of doctors would make the sensible business decision to make a good living by being part of the New York Health Act. And they would make a good living. The bill guarantees that.
Oh, and that's my next question is, if you're talking about adequate income or adequate payments for particular treatments, the cost of living in Utica or Syracuse is far less than New York City. So who determines what adequate is? Is it something for Utica or something for Manhattan or Brooklyn?
Okay, well, first of all, the bill does acknowledge that there are lots of different kinds of healthcare providers, there are lots of different kinds of hospitals, and there are lots of different geographic areas in the state with different economics. And so the bill explicitly authorizes varying rates. The bill also empowers healthcare providers to come together and form negotiating bodies, essentially like unions, to collectively negotiate with the New York Health Plan. And it says that if they don't come to an agreement, there would be an independent arbitration process that would settle the disputes. Plus, the law would be guaranteeing a level of reimbursement, again, based on a variety of factors, not based on just a dictate by the plan.
Thank you. And then Medicare is rife with fraud. I think Florida is a particularly bad example of it. How is that going to be monitored? Will there be an enforcement division? And also, given that some groups of political powerhouses want to see a lot of privatization, how do we know that at some point in the future, this whole thing wouldn't try to be privatized?
Well, the answer to the first question is, yeah, the state would be in the business of catching fraud. And because there would be only one health plan, not a multiplicity of health plans, defrauding the system would actually be a lot more difficult. The level of fraud in Medicare, I don't know about Florida, but in New York, the level of fraud in the Medicare program is actually a lot less than a lot of the scary headlines you may occasionally see. But it's a lot easier to police a system with a single payer than a system with dozens or hundreds of different payers. Among other things, it's harder today there is a fair amount of double billing where people bill more than one health plan for the same service. That would no longer happen under the New York Health Act. So whatever fraud there may be in the current system would be easier to catch under the New York Health Act. I forget what your other question was.
It just was about privatization, if that were ever to occur.
There's no way to guarantee that years from now the legislature might completely go nuts and completely forget about what the world was like under a private insurance system and abolish the New York Health Act. I suppose that could happen. It almost never happens that a public benefit that's available to everyone, that the legislature cuts back on it. Why? Because people learn to love it. I suppose next year the legislature could decide to abolish public schools and send all our kids to private schools. Probably not going to happen. Hasn't happened in about 240 years that we've been having publicly funded elementary and secondary schools in New York. Now, you're looking at me like, oh, that would never happen. What makes
I'm looking at you like charter schools.
By the way, if you think that 20 years from now, the legislature might completely lose its mind and send us back to a system of private health coverage, well, at least we will have had 20 years of good health coverage. If we don't enact the New York Health Act, we don't have to worry about the legislature sending us back to a hellish, horrible, terrible system, because that's what we're living with today.
Thank you very much. I was just looking like this because I was thinking of charter schools and how that is a way of funding something other than public schools, but that's another conversation. So I'll stop here and thank you very much.
Okay.
We have one more question from a member of the public, Steve Simon.
Yes, I'm sort of an interloper tonight. I'm the chair of the Community Board 12 Health and Environment Committee in Washington Heights and Inwood. And my committee passed a resolution in support of the New York Health Act a few years ago. But let me ask a question anyway. Would there be a residency requirement? Would you have to be a New York resident for 30 days or 6 months or so before you qualify for this coverage? Would we have a situation where people would suddenly be moving into the state to quickly establish residency to avail themselves of these benefits?
Well, there would be a residency requirement. I mean, you would have to be a resident. The bill does not define, how many days you'd have to live in New York in order to qualify as a resident. That would be something that would be a regulation that the plan could adopt. This notion of people flocking to New York from other states. We've had experience in New York where New York has had much more generous benefits than every other state. And there was never any evidence of people flocking to New York. In 1990, we enacted Child Health Plus. The only other state that had Child Health Plus was Minnesota. There was never any evidence of families with sick children moving to New York to take advantage of Child Health Plus. There have been years when New York has dramatically increased income eligibility for Medicaid. There were years when New York covered childless adults, where we were like the only state in the union that provided Medicaid coverage to childless adults. And yet there was never any evidence of people moving to New York to take advantage of our Medicaid program. So while you might imagine that could happen, there have actually been historic examples where New York has had much more generous benefits. And even today, New York has more generous benefits than other states. And there's never any evidence of people flocking to New York to take advantage of those benefits.
Well, thank you. That's an answer that I can use. So that's very much to the point. Thank you very much.
You're welcome.
Is there anybody else, Rebecca? Or can I?
Oh, Ellen just raised her hand again.
Okay.
So just to follow up on that, what happens to homeless people? We do have a lot of homeless people flocking into New York.
Well, I don't know that we have a lot of homeless people flocking into New York. I've never seen any evidence of that. Our homeless people are homegrown. They are New Yorkers who lost their homes in New York. I don't see any evidence of homeless people flocking to New York. And the answer is homeless people are residents of New York. They may not have a home, but they are residents of New York. They're entitled to a lot of benefits. They're entitled to register to vote, by the way. And they would be entitled to the New York Health Act, as they should be. Yeah.
Can I go next, Rebecca?
Yep, take it
Okay.
away.
First of all, I just want to say, if Dick, if we did get a whole load of people flocking into New York, I see great benefits. We'll get more businesses, more people buying houses, more people doing some of the work, and I think that could be a plus. I just have one quick question and then going to make a statement. A quick question is what do you see as the health and hospitals future if this is passed? I'm on the board of the Metropolitan, which is in Spanish Harlem, and I think it's a great hospital. I was just tested there. Do you think it will change, or what do you think will happen?
I think it will be an enormous benefit to the Health and Hospitals Corporation. And this isn't just me talking. Mitchell Katz, the president of H&H, strongly supports the bill and speaks out for it frequently. And you know, he's not a crazy man. He wouldn't be saying that if he didn't know that it's good for H&H. And it's good for H&H because it depends heavily on Medicaid and Medicare. And both of those plans will get people under both of those plans. Their coverage will get paid a lot more under the New York Health Act. And H&H cares for a lot of people who lack health coverage or who have high deductibles and can't afford to pay their bills. People who walk in the door of H&H from now on under the New York Health Act would all have the same health coverage as people who walk in the door at NYU or Columbia Presbyterian or anybody else. H&H would do extremely well under the New York Health Act.
Yeah, I know they would. I didn't know whether it would change. I'm just going to ask, and I would like Steve Simon. It's so nice to hear Steve Simon with a different hat on. I'm used to hearing him in Parks hat, right? And then maybe he can help, and I'd like your opinion. I asked you this one pre-COVID several years ago. We attempted to pass a resolution. Our committee passed a resolution and the full board didn't pass it, tabled it, because they felt there wasn't enough specifics. They weren't able to ask. Would you rather have us try to pass it where it may not pass in the full board, or is it better if we don't? What is your feeling? And Steve, maybe you would help and say, how did you get it passed? How, you know, and so on. So just give us some guidance with that.
Yes, I would much appreciate it if the committee would approve a resolution and try to get it passed again. You know, if the board says, well, we have questions, I would say take their questions, and chances are most of the questions they'll ask are the questions that were asked here tonight.
Is it possible from somebody in your office to zoom in and maybe help us out? Or Steve, I don't know if you would, the questions were asked at your community board, you would be able to help if something, you know, I felt sometimes I just wasn't able to answer the questions.
Well, if it would help, a couple of things. One is you could take the questions down and send them to me, and we could send written answers before the next committee meeting. That would be
table it and then come back again. Yeah.
And another option would be, I could possibly have someone on my staff who's familiar with the bill attend by Zoom. Conceivably, I could attend by Zoom.
That'd be great. Okay. And Steve, do you have any suggestions of what happened at your community board?
Well, am I on?
Yes.
Okay. I didn't really find any resistance with my board. We spent a fair amount of time within my committee of reviewing the issue and considering the bill, and we didn't support it right away. We spent 2 or 3 months looking it over and discussing it, and I guess by the time we were prepared to vote it out of committee, we were prepared to push to get the whole board to support it. So I didn't find a problem with my board, and you know, maybe we come at it from a different direction, but we were certainly open to seeing a dramatic change and improvement in the healthcare system.
Thank you.
My guess is that the questions that people had at the full board meeting are probably overwhelmingly the same questions that committee members have been asking tonight.
Some of it was, how much is it going to cost me? Quite truthfully, how do I know how much is it? If I make 80,000, if I make 180,000, if I make 500, what is it going to cost me? And I think a lot of it came from that. A lot of it was, Ellen, you were at that meeting. Some of it had to do with what happens if the state just doesn't have money, like what will happen, can it change? There was, as you heard, one of our members is a retired Port Authority worker and has great health care. What happens with retirement? And there were a lot of questions like that.
Okay, Barbara.
Yeah.
I would say if it's possible for you to put those questions in writing and send them to me, maybe the easiest thing is we can send you answers.
Okay.
I think that would be a great idea. And I think in terms of presenting, and maybe we could think about this when writing the minutes, is kind of taking the misconceptions and giving, the reality right up front to the most common concerns.
Either that or a next meeting, maybe very quickly, just saying that this was tabled over from the last month and these are some of the answers, and do you want to pass a resolution now or something like that? So we will work on it at committee. So do you think it's better if we don't have a resolution now? Or I'm up for anything and I'm voting yes for it if we do have it, but.
Alita?
You're asking the committee.
Yes, I'm asking the committee, or you, Dick, if you have your opinion or whatever. Would you prefer if we do have a resolution? Rebecca?
I see two hands up, but in case you have to go, I just wanted to thank you so much for always coming to our meetings and for all your years of service. I wanted to make sure I got to thank you personally.
Are you still going to be on? Yeah, it will. We'll be in touch. I know we had said just an hour. I just thank you so much. And it's just so exciting that it's a little overwhelming for some people, I know. Some of the questions Alita asked today were asked the last time. So let's decide whether we want a resolution now or how we want to handle it.
We have Alita and then Judy.
Okay.
I just have one question. I don't, and if it was answered, I apologize. What about mental health?
Mental health is completely covered. Absolutely.
Psychiatrists, psychologists, therapists, social workers.
Absolutely.
And any medications?
Yes, absolutely.
What about experimental treatments? Like I read something in the op-ed about ketamine. Is that the right for depression? Does it cover something like that? Ketamine. It
depends on exactly where in the experimental process a given drug is. The law today, in its definition of medical necessity, talks about the various stages of experimental process, some of which would entitle a drug to be covered or a treatment to be covered, some of which would not. And the New York Health Act would apply those standards.
Thank you.
Okay.
Judy?
Oh, Judy, yeah.
Actually, it's Barry. I'm back.
Okay.
Having introduced myself, wishing everyone a happy new year, and let's start the new year right. Move to approve the proposal to pass the act we've been discussing for the last hour and a half.
So we should do it now.
Yes.
You have to back me up when I can't answer the question. When Rebecca and I stand there stammering, can't answer all questions, Barry, okay?
Go ahead.
You'll help us.
Is there a second?
I'll second it.
Lori, that's a second. So we'll take a vote. I guess we should read the list of board members still present.
Right.
I see Barbara and myself, Lori Borez, Alita Camp, Barry Schneider, Ellen Pallavi, Merrill Brodsky, Russell Squire. If I missed you, please raise your hand. All right, so if you would like to vote no, abstain, or not vote for cause, please raise your hand and I'll call on you. Alita?
I'm abstaining.
Anyone else? Seeing no, oh, Merrill?
I vote yay.
Abstain, got it.
Alita, did you want to change your vote?
No, I'm abstaining.
Okay, you keep raising your
I
hand.
couldn't tell if I lowered or raised.
Well, the vote, the resolution passes with 2 abstentions.
That's great.
And 2, 3, 4, 5, 6, 7 yes votes, I believe.
No, if it was 8 people, I thought you said there were 8 people, then it would be 602 or 702. Are there 9 or 8 of us? I counted 8. I may be wrong, Rebecca. You have it. You'll know it.
And I will work on the resolution before the board meeting, which is going to be, I believe, Will, the second Wednesday.
Well, it's the third because the first.
No. It's the second because the
it's a-
third actually falls after a vote that we hope that the assembly member will help us with, which is the extension of the open meetings law hiatus,
Yes,
so that we can continue to meet virtually on Zoom.
Yep, you got my vote on that.
Good.
Thank you.
Thank you very, very much, because we do have a meeting that night as well for a different committee. So hopefully
Right.
we'll still be able to.
And if people can write in questions, if we could like accumulate all the questions, either send it to Zachary or Rebecca or myself, and maybe CCing everybody, it would really help if we can get some of the questions answered beforehand. If you think that's good. I'm a little wary, and I remember, I don't know if you remember, Dick, but we were at one 8-hour meeting, I think was the Physicians for National Health. And I asked you whether we should do it. And, what's better, to have it pass or whatever, but let's work on it and try to get it passed.
Okay.
I see Barry has his hand up.
Yes,
Yeah.
one thing. Will, would you, when this is, when the vote is tallied and accurate, would you send a copy of the bill, not the resolution, but the bill to all community board members, so that when we convene at the full board, no one can say, gee, I don't even know what's in the bill. They'll know what's in the bill.
Perfect. Thank you.
Thank you.
Sounds good. We'll make sure it's sent around. It was put in the chat earlier by Zachary.
It should be the Assembly. The Senate has a version. The Assembly has passed it. Am I right, Dick? It's up to the Senate.
Several years ago, the 2 bills are identical. The
They are
Assembly and Senate bills are identical.
And right now they would have to be passed by both houses, right?
Yes.
Okay.
Okay,
Great.
I'm going to say goodbye.
Thank you so much again. We'll
Thank
see you
you.
about another 5 times before you retire.
Oh, who knows? Who's counting? Okay.
Thank you so much.
Bye-bye.
Bye-bye. Any old business or?
I see Alita has her hand up.
Okay.
Yeah, one more question, Barbara, if you, and Rebecca, if you want to just take a note, is what happens if your doctor wants you to have a treatment and they say no, and you're in the appeals process, and we all know that time is of the essence for some medical issues, maybe all medical issues. So what, do you have an option of paying for it to get reimbursed if you can in the appeal process, or are you precluded from getting that treatment at all? I mean, how does—
Can you do us a favor and write that down so that we'll start accumulating those type of questions?
Okay. I'm going to send it to you in an email right now.
My prejudice, because of my personal situation, is I would love to have like some some countries do have additional private insurance, not instead of, but on top of, and such as what Dick has, where he's able to pay for a doctor that doesn't take any insurance. He's able to still get some of the money back. And I wish I had that too with Medicare.
Right. But he made it sound pretty clear that there would be no opportunity
right.
for additional insurance.
Right.
So then that clearly creates a two-tier system of people who can afford to pay even when the state isn't paying, and people who can't, and doctors who will work with people, and maybe doctors who won't so much. And that's why I abstained. I think I still have questions, and I don't have enough clarity or certainty in the answers to be able to support it. Maybe there's language in the legislation. I haven't read it, and I'll look for it when it comes. But that's really, I know this is probably offline with
if I may, Alita. That's how it is now. We have Medicare, and we have lots of doctors on the Upper East Side that do not take Medicare, or they do and you can't get there, and they're not taking regular insurance either. So we do have a two-tier system. I'm arguing it isn't two-tier because people like me that are not the uber rich are forced, because of my situation, to do something that I would prefer not doing. I mean, I cannot tell you how expensive my medical has been, and I'm sorry about it.
I mean, I don't know personally, but I know how expensive.
If I want to know, I wanted to talk to you about something. The other thing I'm going to say, a comment you made about, will doctors leave? I find doctors are leaving right now. I met a lovely man when I was visiting my family in Greenwich, Connecticut, a friend of theirs who's a neurosurgeon at Columbia, graduated from Cornell Medical School and so on. He's leaving Columbia and would rather go to the Greenwich Hospital, which I do not believe has the clout that Columbia Presbyterian has, because he says it's become so large and cumbersome and awful that he said, I can't take it anymore. It isn't, he said, the transportation is nothing. He drives in like 30 minutes and it's not a big deal. It's just too hard of a hospital to deal with. So we right now are having major problems with our healthcare. Doctors are leaving. I've heard of doctors that just say, I don't want to handle this anymore. I do believe that those doctors that want excellence, I don't think any hospitals are like our Cornells or MSKs or special surgeries or anything else like that. So I do think that those doctors that want to be surrounded with the excellence that they are will stay here. So that doesn't worry me as much. We just have to get all of the specifics. That's my platform.
I do have some questions that I will add to our list that we'll email to the assembly member. I mean, one of them, which I'm sure the answer is yes, but
before you send it to the assembly, can we just combine it all? Let's try to get it.
No, that's what I mean. But I, like, for example, one question, which I believe the answer will almost 100% be yes, but we should get clarification on, is will children or who attend boarding school and therefore might not be in New York State for a certain amount of time, or children or people in college, will they still be covered if they're out of state? I have a feeling it's yes, but I think we should double check on that.
I think he sort of said, let's even talk about others. What if you are lucky, like Ellen Pallavi, that's able to spend months in Florida? If you're I think that what he'll say is if you're a New York State resident, which the children are, and I also write it down and we'll ask. I don't hear you, Rebecca.
This committee. Can you hear me?
I can hear you. Now I can. Yes.
I believe one change from the last time the committee voted to in support of this bill is that now, even if you're not a New York State resident but work for a.
Oh, that's another question we didn't ask. Right.
But I'll write that down and make sure.
No, I don't think so. My memory is, let's write it down, but my memory is that you would not be part of it, that your company would then still have to have an HR department.
I think they changed that in the most recent version of the bill,
Okay,
but we
that
can
would be
double check.
interesting. We didn't ask about employee. So please, let's everybody, if you would write the questions, it will make it a lot easier. There are a lot of questions that were asked, I remember, and I'll go through my notes and try to see if I could find some of the questions and some of the answers that were there. Can I just talk about what I'm sorry, no, you finish.
I was going to say any old or new business.
Yeah,
I see Ellen does.
I just wanted, let me just quickly talk about what I think next month's meeting going to be. For some sort of strange reason, another part of our health, our health senior social services committee is judicial justice. And next month, there have been so many questions about what's happening, not statistics in our area, but how is the bail bond changed? What's happening with Rikers? What if they let people out? What is some of the security? And with the new change of not only mayor, but also what's happening at the state. I spoke to Dan Court, who would like to talk about it, and maybe we will find who's the head of public safety on a city level and to revisit that information. It'll probably be next month or possibly March. Who's the next one, Ellen? Somebody else? Okay, thanks. Ellen?
Oh, so I just wanted to know who's collecting all the questions.
Should we send it to Zachary, or do you want to send it to Rebecca or myself, whichever? We'll send it to Zachary. Okay, Zachary, do you mind?
Yeah. Send them. I'll collect them and everything. You guys will just send it to my email. I'll put it in the chat right now.
Okay.
I already put the email account for the office in the chat, so just send them right there, or if you have any of our email addresses, you can send them.
And then the public can do that also, and we'll accumulate them.
Well, who's the we? So sending it to Zachary.
It's like Zachary, Will, Rebecca, Wilman, and I, and so on. And we'll accumulate the different questions and try to get the answers from the assembly member.
Okay, so can we possibly send it, like start a group chat, like a group email?
I don't know if we're allowed to do it.
Just so we know that we're not double asking the questions, or can we find the questions?
If there are duplicate questions, we'll only ask it once. If we can combine them, we'll do that. I don't think we're going to have a big email chain because of the open meetings. Well, I could be wrong, but.
Is Steve Simon still on? I wonder if Steve would come to our meeting and,
he's not.
Oh, he's not. I will contact him, or Barry, I'll ask you to contact him. We're used to Steve Simon is the chief of staff of the parks. And so we're used to talking to him in terms of parks. I was surprised to see the different hat that he had on.
If there's any old or new business, please raise your hand.
Thank you. Great. We look forward to seeing you again, and a lot of food for thought. And now those that didn't
Happy New Year,
have
everyone.
food for food. Happy New Year, safe, and so on.
Is that a motion to adjourn?
Motion to adjourn. Thank you, Will. Thank you, Zachary. Thank you, everybody else.